Good afternoon. Welcome to our first webinar. I hope that you'll let us know by the end whether this particular format is useful to you. For years, we've been engaged in workshops face-to-face, and you've had to come and find a place to park and have a chance to participate. And we're really hoping that by use of the webinar, we can expand that opportunity to those of you who aren't here on the Westwood campus. There will be others joining us as we go, and one of our goals is that we actually are able to interact with one another. We have three critical areas that I will spend some time with you this afternoon on. First, we're really looking at how to lead a discussion from a slightly different perspective. Rather than thinking about the skills that you need for facilitation, we're going to be thinking about the structure that you might give to a discussion that takes into account what we know about how people learn. And so we're going to look at three very important features associated with learning that are relevant to the clinical and medical education and dental education setting. We'll take a look at the work around pre-existing knowledge and its importance in learning, organization of new understanding, and personal awareness, and how these suggestions from the research literature on learning can be helpful to you as you plan for and lead a discussion. We'll think a little bit about your own preferences and plans, and we will identify as we go through this period together some essential facilitation skills with your help. So as we began today, I wanted to start with a poll. So these are the issues that we're going to be thinking about, but I'd like to know a little bit more about you first. So from the first poll, you're going to be able to answer a question. I'm going to launch that poll now, and I'd like to give you a few minutes to fill it out. So the question is, what type of discussions do you most commonly lead? Problem-based learning tutorials, largely for our medical students or dental students, case discussions that might be residents in a conference room, students in a classroom, attending rounds, a topical discussion, not necessarily case-based, could be happening in a classroom, conference room, or lab, or any other. So I'd ask that you spend a few minutes, a few seconds, if you will, responding to this question. 50% of you have voted, so take a moment more. Let's see who's in our group today. %, 88 voted. Everybody has voted. So let's look at the results. So it's very useful for me to know as I think about today's session that this is pretty evenly distributed in terms of who's on the webinar with us today. And so we'll try to think not just about the attending rounds, but we'll also try to come up with ideas and suggestions for leading discussions in these other situations as well. So if you wanted to learn a little bit more beyond today, I have suggested down here a book that's written for university faculty members, and it does touch on each of these issues if you are interested in pursuing this any further. So when we think about how people learn, it's often helpful if we use a situation to as sort of context for our discussion. So you have all received a handout that was a case study called Multiple Realities. I've put a little bit of the summary here, and I'll go through some of that. And the reason that I wanted us to start here is to give a context. Even though I see that we are teaching in different kinds of discussion settings, this will give us at least one context that we can begin to analyze as we think about this learning situation. So as I tell you a little bit more about this team and its attending, be thinking about what barriers to learning exist in this situation. So this attending is new to the team, and earlier that morning he has paged the senior resident and asked that resident to identify a recently admitted patient to discuss for the first few minutes of teaching rounds in the conference room. The resident has picked a patient, and that patient is one being cared for by a third-year medical student, Roberta. So Roberta is ready to present her patient. She isn't exactly sure what he is expecting, but the intern coached her earlier today, and she had a chance to practice, so she's pretty sure that she won't need her note cards at all. She's really ready to go, and feels pretty confident if she isn't interrupted. So when the attending joined them in the conference room, the senior resident introduced everybody quickly and then turned to Roberta to start. And in the group now we have an intern, a PGY2, a third-year medical student, the second-year nursing practitioner student, and the senior resident. So the attending says, my goal is for the student to present the case, and Roberta begins quite confidently. Here I would suggest that you look at the handout if you didn't have a chance to look at it previously. She gives quite a thorough history about the child, who was born at home 11 months ago. 2 months ago, she started to take less breast milk, to cry, to sleep less. There was no weight gain since her last ambulatory visit to the pediatrician, and very little since birth. 7 months ago, she had a retropharyngeal abscess, which surgically drained, and that fluid grew out Staph aureus. So she goes on through the situation with this child, and at some point, the child is admitted for a further workup. And at this point in time, the mom has stopped force feeding her, and the child seems to show slightly more interest in food. So when Roberta paused to check her notes, the attending interjected. Can I interrupt you with questions about the history? At what age did she have abscesses? Did she have allergy workups at any time? How long after discharge from surgery did they check her protein and albumin? My point is that you don't give protein NPO, which is a possible explanation for her low values. I would want to repeat those tests. How long post-op did she do well? Did she show weight gain on isomil? That would be really important to know. He then left a pause, and so Roberta's intern, Greg, supplied some pretty brief answers. When the attending was satisfied with the information, Roberta continued to present her physical exam, followed by another round of questions from the attending. Was the skin doughy? Did she exhibit elastic recoil? Did she have wasting of the cheeks or temples? What lab work are you planning to get? Now, Roberta was ready for this one. She and her intern had discussed that at length, and she very quickly offered her 2 suggestions, SMA7 and LFTs. Total protein. Be sure to include total protein, interjected the senior resident. Roberta wasn't quite sure she had finished her own list, but the attending nodded, and the intern then took over and outlined the remainder of the plan, and then turned to the attending again. The attending said, if you had to characterize her failure to thrive, Roberta, how would you do it? Now, Roberta hesitated. She was a little puzzled by exactly what he wanted, and so the attending continued. It's worrisome. I would call it severe failure to thrive. There are 3 categories, something structural or mechanical, something environmental, for example, not adequate food or climate, or something organic, like she can't use her intake, metabolic protein-losing enteropathy. Let's go over and see how to work up each one. First, for number 1, get a baseline status. The attending continued then in this vein, outlining the approach to the workup of these different types as he stood up from his chair and used the whiteboard in the room to sort of flesh out the tasks that he felt was needed. About 5 minutes later, he felt satisfied with his explanation and pleased that he'd had time to teach even when the service was busy. As he sat down, he smiled at Roberta. Nice presentation. Be sure you avoid making the mom feel guilty. Put a growth chart in the folder. Decide how long to wait. And in the meantime, get a dietary consult. Now, let's get down to work. Who else is on this service? So lest you think I made this up, I was on another member of that team that day, just watching quietly from the back, and immediately began to wonder, what are the people in this group learning? What do you think they might have seen as barriers to learning? So I'd like for you to think about that for just a minute. This is not an atypical situation. finding a team in a conference room, talking about a newly admitted patient, attending, sharing some information. What might be some possible barriers? Anybody have one to offer? You can raise your hand using the little hand on the right-hand side. Dr. Gaffori, I'm going to unmute you. Any thoughts? You should be able to comment, just audio. Okay, perhaps not. Let's do it this way then. If everybody would, for the moment, write down a couple of concerns that you might have. If you were the attending and you intended this to be a case discussion as part of attending or teaching rounds, what might you be concerned about as barriers to learning? I'll just give you a moment to think about that. Dr. Gaffori has noted that the different levels of knowledge in the room could pose one barrier to the type of opportunities for learning in this situation. Different participants in the group may well experience very different background about this. Dr. Sachs has suggested that the student may be uncomfortable and confused, and certainly under those conditions, our student, Roberta, might not be ready to learn. One that occurred to me as I was watching was the lack of true discussion, that others in the group did not have many opportunities to connect. Dr. Oning suggested that this is an example of academic waterboarding. Interesting choice of terms during rounds. All the attendings' questions were rhetorical. He just wanted to impress the team with his knowledge rather than eliciting a response. Now, I was very interested in his comment that he felt like he really had done a good job of teaching because he had that time. Dr. Weinrab thinks that the attendings taken over the case, and really by asking the questions that might provoke some discussion, he didn't really allow time for answers. So even when we think we might have done a good job, there are always ways that we might do better. In this situation, I want to start with the first suggestion, which is everybody in the group has a different level of understanding. Now, what we know from research on acquiring new knowledge or new understandings is that the pre-existing knowledge level of the individual learner is a very essential basis for acquiring new understanding. Prior experience can often facilitate the accommodation of new information or the blockage of new information. In looking at the pictures here, if a learner is trying to distinguish the cardiovascular system and how it works and the basis of blood pressure, but has in mind that it's just like plumbing, there may in fact be some prior knowledge that is actually going to get in the way rather than help with that understanding. So when we're thinking about who are our learners, we have lots of things to be concerned about. What have they already learned? Where are they in their rotation system? How many of them might already have a PhD in the areas that we might be discussing, or a great deal of prior experience? What have been their recent events? We'll talk about that issue in just a moment. So there's a kind of ecology of their experience that might be important for us to understand. There may be some issues around culture or social roles, around gender or ethnicity. There's many features to take into account when we're thinking about the importance of pre-existing knowledge. Now, the reason to spend a little bit more time thinking about who these learners are is that misconceptions and misunderstandings are really hard to change. We assume that you just replace them. No, that's incorrect. Here's the way it should be. But unfortunately, the research suggests that simple replacement is not always guaranteed to take. The picture here is from a very funny study of first graders learning about gravity. So in this study, they were asked to draw what would explain the way in which gravity works to help people stand upright on the earth. And you can see from the picture on your left that they thought of the world as a rather flat and that form of a round work. And so if that world were shaped that way, of course, it would be very easy to stand up. Then after the instructions, after the teacher had given a short lecture and some demonstration, she asked them to draw again what that world might look like on which gravity sustained our ability to stand upright. And as you can see now, the world has indeed become round, so some part of that new understanding has taken hold, but there's still some sort of plate of some kind on which people are standing in order to remain upright, given the problem of the world being round. So the point in this example is that there are many ways in which misunderstandings and misconceptions can block our ability to understand new information. From Jerome Groopman's book, How Doctors Think, he suggested several that we would want to think about in terms of biases, common biases that influence clinical medicine and decision-making discussions. So representativeness is that we have a strong prototype in a particular domain, and it causes us to see that first, or to be limited in our possibilities because the prototype is so strong. Attribution has to do with we've seen something fairly recently. It is the cause of a patient's problems that we've just cared for. It's a problem with a treatment. And so we attribute some power to that previous, very recent event that blocks us from new understanding. Sometimes affective preference, we are drawn very strongly to a particular patient in a positive way. And so as new data might emerge, then we overlook some things that might be bad news for that patient. Availability has to do with how much of the information is readily at hand, how many steps we have to take in order to acquire a fuller picture for the decision we're about to make. And confirmation is the idea that sometimes we only collect the data that will support our hypotheses and fail to carefully consider the data that would rule those things out. In other words, when our learners are attempting to build their own knowledge base, to develop their understanding, they're affected by not just their preconceptions, their prior experience, but also these biases that can influence the way we all make judgments. Okay, we are going to take a poll, so you should be able in just a moment to see a new question, if you will. This time, I'm going to ask what you would most likely use if you were going to work with this same team. So which strategy would you most likely use to build on the pre-existing knowledge and experience of the various team members in the case that we just talked about? Would you prefer to take the time to find out something more about each member of the group? Could you ask how you might be most helpful in discussing the case for this members of the group? You could encourage the learners to ask questions so that you would know where their confusion or clarity was. You could ask the learners to be ready to answer one another's questions, thus drawing more members of the group in. Or you could reassure learners that they can reason on the basis of what they know. They needn't know everything that's there. So let me ask you to pick one. They're all okay, but what would you be most likely to do? Really thinking about yourself. Okay, let's see what our group is interested in. So once again, we have a nice spread here. So it seems like of particular importance is that ability to take a few moments and find out something more about group members. You might want to do something more than the senior resident's introduction, which is purely, this is so-and-so, and this is their year of training or level of training. And I'm sure that you have some personal favorites that you like to ask groups in order to learn more about them. The second most frequently chosen one was reassuring the learners that you want them to get involved, that you may ask questions and they may ask questions, but you want them to also be the source of an explanation. So while all of these are possible responses, there are some ideas about from the literature on things that might be particularly helpful. Let me take you back to a few suggestions. So when you're thinking about activating prior knowledge and experience, the first most critical tip here is to set clear expectations. So our attending in the case study didn't really say much. The senior resident may have known, but take some time to find out about the learners. And that was indeed the most frequent thing that you shared in the poll. You should expect learners to ask questions and share their own problem solving and encourage them to answer each other's questions. You also want to try to elicit some of their understanding and experience by giving them the first chance to answer, the first chance to come up with a plan, the first chance to come up with a differential, the first chance to offer an explanation. As you listen to that first chance, you'll have a better sense if there are misunderstandings or biases that you need to address more directly. You can reassure them that even if they don't know, some of you chose this one, that they can start with what they do know, because it's safe to be wrong. Reassuring them that this answer or this contribution will not be considered in the grading in their future. The other really interesting idea, and I think one of you mentioned this as well, that if you ask multiple questions and you don't allow any wait time, you won't really hear what the understanding in that group is. The multiple answers, the more people you get to answer, the more in-depth the answer is, requires waiting. There's been some research in higher education. I'm not sure that it's been repeated in the medical education or dental education setting, but there's the 3-second rule. So the average amount of time that we wait after asking a question is 1 second. And by manipulating that 1 to 3 seconds, you can get more people answering and more in-depth answers. So just a little tip for thinking about how you're going to use the questions that you might ask. And finally, you want to think about questions that would help you uncover common biases and misunderstandings, and not just depend on the power of simply correcting something that is incorrect or incomplete. Okay, as we think about our work as a discussion leader, then this first idea is that you want to build on the prior knowledge and experience of your team members, getting to know them, asking them, giving them the chance to answer first, taking a little extra time to allow that to happen. And remembering that sometimes misunderstanding is coming from these sources of bias and should be addressed more directly. All right, our second idea. We'll still stay with the case. I know some of you are thinking about PBL, and some of you are thinking about more topical discussions. Those issues might be even more important as we consider knowledge organization. So what research suggests is that knowledge that can be organized in a more conceptual fashion allows us to transfer it more readily to new situations. We do have a tendency, all of us, in life, in clinical work, and science, to develop patterns because that reduces our cognitive load. So there's some belief that in medicine, a very large percent of the diagnosis that you make come from pattern recognition. But knowledge organization has to be tested as well. So the issue here is, what do we know during a discussion about how knowledge is being organized? The research in this area particularly comes from the work that's being done around how novices become experts. The differences that are found, and this research, a lot of it has been done in medicine. It initially started off in chess, but they've studied many different disciplines and medical specialties. And there are two basic patterns. So for our beginners in any field, and a novice might be a very early beginner, or a third-year medical student might be a novice, even a fourth-year student or an intern, once again, being thrown into a new context, might return to the novice level. So at the novice level, we tend to work with fairly rigid boundaries. So you learn an idea in one context, and it gets embedded in that context. Whereas for experts, they have many interconnections amongst ideas. If you ask them to draw a map of a particular set of ideas, they see many ways to connect. A novice focuses on the surface features. So when discussing a case, may be able to report on the many details of the history or the findings in the physical exam, but not necessarily link those surface details to a pathologic mechanism or physiologic or pathophysiologic mechanism, or to a disease type to be considered. A novice is looking at 1,000 points of light, many isolated facts, whereas you as experts in clinical and scientific practice have made chunks or patterns that give you a shortcut to accomplishment. For the novice, making a decision, committing something for long-term retention is slow and effortful. For you, as long as you find a link to something that you already know, it's a fast, effortless kind of structure that emerges. Because you know what the task relevant connections are. You know not just the fact itself or the concept itself, but you've also embedded with it something about when it's applicable, when it's going to be most useful. And you also know when it doesn't apply, so that you know how to adjust the current situation to decide whether your knowledge fits it or does not fit it. So for the novice, none of that is present. Now think about a discussion. If you're giving a lecture, you can deal very straightforwardly with organization. In a discussion, there's less control. So let's think, once again, using our polls, what might be a really useful strategy when you are trying to help in a discussion develop some sort of organization. So select only one of the following. Do you think it's best to summarize major points of discussion at the end to illustrate the organization? Something the teacher would do. Do you think you might be better off providing a handout of points and references at the beginning? What about asking learners to compare and contrast the discussion today to similar problems or cases? So kind of what if questions. What if the person were older or younger, or the sputum was green or clear? Or asking learners to construct a timeline for the case so they began to move more systematically through the data. These are hard choices. They might, as before, all be appropriate. But which one of the strategies might be most helpful if your goal is to help with creating some form of organization during a discussion? Still have a few more folks to vote. All right, let's see where we are. All right, half of you thought that summarizing major points at the end of a discussion might be a really useful way to help create an organizational structure. A slight variation on that is that perhaps you don't have to be the one summarizing. It's possible that that summary might be provided by the group itself or by a single member of the group. Certainly handouts are always useful in any kind of learning situation where at least we can make it clear what we hope the objectives of our work together will be. We can use questions throughout a discussion. The compare and contrast, the what if kinds of questions, which I know many of you probably use, can help learners create organizational patterns. It might be that we don't point to them clearly enough, that we don't use them to very explicitly help construct an organization, but certainly those are great questions for helping the learner see the similarity to other situations. The timeline for the case may be helpful in making a specific diagnosis or deciding on a treatment plan, but may not be as helpful for organizing new knowledge. However, any kind of diagramming can help a group begin to put those results together. All right, so let's see what the literature suggests as some other strategies for this. How can we structure discussions? So what can we do if we think about it? We can ask learners to generalize from specific instances to new situations. So recognizing that prior experience is important, we can also help them by saying kind of, so what? So you found this or that in this situation. So what does that tell you? What kind of problem? We can use strategies that help learners to place individual knowledge or individual facts into a larger framework. Things like concept maps or diagrams, timelines, as we suggested. Even a compelling patient story. Students in problem-based learning really appreciate not an overload of compelling patient stories, but some examples that help them to understand exactly how this might play out with a real patient. Questions such as how and why and when can also help the learner begin to create a structure. And timeout for preview before you start with a handout or without a handout, and for review at the end, those sort of summaries that many of you thought would be helpful, are wonderful ways to help create organization out of what some students see as chaos. I was with a group of surgery residents, and we were talking about what does it mean to generalize from a specific instance. That didn't make any sense to them because each patient was an individual that needed to be cared for in a specific situation. And while that is indeed true, when we are trying to help our learners move from that one case to cases they might see in the future, then these questions of relationships are very important and generalizations. We can also prompt explanations rather than brief answers. An explanation tends to pull from the person offering it a little bit more of the detail. Why would they do that? When would they do that? In which they might automatically begin answering the how and the why and the when. So one of the tools that's very useful for us as discussion leaders is the phrase, say more about that. Tell me more. Okay, so third big idea from the literature on learning. It has a fancy name, metacognition, which now you can say you know a good psychological term here, but it really is personal awareness. The effective learner is engaged, personally aware of his or her own thinking, and has the ability to reflect and to plan. So some of the skills that are needed by our learners as they become more personally aware are they have to be able to set some goals. To do that, they need to know, when do I need some personal learning here? Where is my gap? And in problem-based learning, they're often confused by, is this a gap in the literature or is it a gap in my understanding? And here we're really talking about their being able to identify gaps in their own understanding. One of the strategies I saw an attending use at another institution was after meeting everybody on the team that first morning and finding out which case they wanted to start with, he then says, well, how can I be most helpful to you? No one said anything. I timed it. It was almost 30 seconds, which is a very long period of time of silence. And finally, one of the residents said, you're serious. You really want to know what we need from you. And then the discussion took off. So having them identify where they think they might have a personal learning need can be extremely valuable in seeding an interaction and a discussion. Metacognitively aware thinkers check and double check their answers. So if they are considering a pattern, a very common pattern, then they will double check it against new data. They'll acquire more data from the history or physical exam or lab or studies in the literature in order to double check those patterns. A metacognitively aware learner can reflect on experience. Think about what went right. What didn't go so well? What would I do differently next time? Now, this next characteristic of the metacognitive learner is one, well, I still have trouble with. Perhaps you do too. And that is, how much time is it going to take and how many resources is it going to take? Because we probably all misjudge. So some practice and some feedback on, is this reasonable? Can you really do this in the amount of time that you have available? And for problem-based learning tutors, this is an important issue, and what questions and the size of questions that your students might select. Predicting outcomes, so understanding our own ability to work with probabilities, to know where those probabilities come from, and to be aware of any biases, such as those we talked about earlier, that might get in our way when we're truly trying to predict the next best step and what might happen. And as I think about our residents, perhaps they're less good at predicting outcomes because many of the patients that they might be responsible for, they don't see in the long run. They perhaps don't see them in a continuity clinic. They're discharged from the hospital and they don't know what happens after that. So this might be a special area of work in our discussions as we help our residents in particular to learn how to think through what's going to happen if. Recognizing their personal limits is when do they need a consult, when should they consult the literature, when should they go back and ask more questions or do more testing. And finally, this last one is more of an attitude, a belief that they can get the work done. And as we approach the time of year where burnout occurs, largely around the holiday season, mid-year, particularly all of us are a little prone when things haven't been going quite right to lose some of that personal efficacy, the sense that we can do it. So our goal in leading discussions is to use the discussion process as one way of really helping to build our learners' ability to be metacognitively aware. So any thoughts on things you might do in a discussion that would help us in this area? Anybody have any ideas? Wanted to stress some aspect of metacognition. You're the attending. You've seen the discussion or lack thereof. Any thoughts about what you might do? You can use the question board, and I'll share those responses with the group. You can raise your hand. I've been talking for a long time. Maybe I'm the only one here. Okay, I'm not waking anybody up, and perhaps this is a hard thing to address, in a discussion. But there are a few tips from the literature. So one thing we can do is ask the learners to participate in making a plan for the discussion. Certainly those of you who are doing problem-based learning and have students who've already been through another group, perhaps those students have an idea about how the time might be spent and what would be most helpful. Certainly as residents and students move from one team to another clinical team, they might also know what has worked best for them. They might have some ideas about how much time we should spend on various parts. Audience response systems in a larger group discussion are a useful way to find this out. If learners in an audience response question using a poll, such as you used, see that an area's 100% of people are fine, then that is a way of having your participants help you decide how to plan that particular session. So we do have an issue down here. Just a moment, a suggestion from Dr. Owning. So he says he always reviews the endoscopic findings with the referring medicine team of the intern or the resident, and this gives direct feedback on their referral decision. So a real chance for them to go over it with an expert so that you can hear, it sounds like, from your expert position, sort of how accurate they've been or how insightful they've been in interpreting those findings. So that will help you decide how much time you need to spend on those various findings because you have heard from the group first. They've really helped to set the plan. We can turn learners' questions back to the group as another way of helping different members of the group to think about, what do I really know? Once again, here we might need to use the 3-second rule. Since I tried for 3 seconds just a moment ago and gave up, somebody said that you need to get used to how long 3 seconds is because it seems like an eternity, but it's really not very long at all. So letting other people in the group contribute will help them in deciding what they really know and don't know. Another strategy that is often useful is have everyone make a private commitment. So when we were thinking in the beginning about this case study, and I said, what kinds of barriers do you think might be in the way of learning in this group with the attending and the failure to thrive case? Hopefully, you had some ideas, even if you didn't get the chance to share them, so that everyone could have made a commitment, and then we could begin to discuss so that everyone was engaged in thinking about what they already knew. Feedback, you've mentioned, Dr. Henry mentioned that feedback was important, so encouragement and reinforcement and praise are tools that we can always use as we help our learners decide that they are accurate or they're not as accurate or they have gotten more accurate as time goes on. And sort of the most obvious thing that we can do around helping our learners become more metacognitively aware is we can actually reflect with them. One of our attendings in surgery likes to say as they end a discussion with a particular patient, so after all that, what do you think this patient most needs from us right now? Reflecting on the event, reflecting on the discussion, and being able to decide what's needed next. Now, does it take too much time? It needn't take long. He actually does it while walking on to see the next patient. Okay, so let's go back. We've thought about 3 issues in that scenario. We've thought about how to activate what our group already knows, their prior experience, and how we might deal with misunderstandings and misunderstandings, if you will. We've thought about how to create some organization when sometimes discussions seem a little chaotic. And we've thought about creating more personal awareness amongst our learners. So let me ask you now, using the reflection, to go back to that scenario. Go back to our attending. Now, perhaps failure to thrive is not something that you work with frequently. So we won't ask you to decide whether there's anything accurate or inaccurate, but looking at the process. If you could rewind the scenario, you've just arrived with this new team. What do you want to do? So I'd ask you just on your own to list down 3 things that you think you might do as the new attending for this team that would promote learning and reduce some of those barriers. So I have one suggestion from Dr. Oning. She says, let the presentation develop without immediate correction. So not interrupting that student who's trying to present. Even if you see that a novice learner is going in the wrong direction, let them proceed and ask questions as to their reasoning. They will rarely paint themselves into the same corner once they have done it the first time. This helps get them beyond facts to reasoning. So the interruptions might be something that restricted your ability in that original scenario to really know what this group is thinking. What are they considering as the key problems that need to be addressed? There wasn't time. In fact, the questions that he asked, you look back at that handout, they're all about the patient. There were no questions about the reasoning, about the decisions that needed to be made. So not only letting the presentation proceed, but perhaps taking it a step further, not stopping with the data, but going to the commitment might be really helpful. Let's see. Dr. Sachs ask about the learners before starting. So do you have any particular kinds of things you like to know about your team? Often nice to know, were they on call last night? Maybe you knew that from looking at who's on who's going to be in the attending rounds. How many other rotations might the students, the nurse practitioner or the medical student, have gone through? Whether there's any particular concerns, as the attending I saw, who asked, how can I help? So there are ways that we can ask about the group. Dr. Weintraub says, I like to introduce myself and tell a little bit about myself and my interest, and then ask everyone else to introduce themselves in much the same way and to tell us something about their goals. So we had hoped that we'd be able to do some of this via audio. Dr. Weintraub, are you linked into the microphone on your computer? You might comment rather than having to write. No, I guess not. Okay, well, we'll keep using the questions section. Dr. Gafuri said that a new attending might start by outlining expectations before the start, so that there is some understanding about what this group is going to do together. In fact, that's part of the organization that the group will need in order to begin to put together some of those organizing features of a discussion. Dr. Oning, I'm probably saying that wrong, I apologize. Oning says, ask more open-ended questions. Ask, what sort of physical findings would you look for rather than, did you see whatever? So once again, you're coming more to the point of questions that are more about the reasoning and the commitment and the decisions to be made. What you could see our attending was doing was he was diagnosing the case. As a teacher, we have the responsibility of also diagnosing the learners in real time, both at the same time. So the kinds of questions that Dr. Oning is suggesting are the kinds of questions that we can use to diagnose our learners and what they need from us. What sort of physical findings would you look for? We'll tell you more about them than about just the patient. Okay, thank you for helping with our attending rounds. Just a few take-home points as we wind up for this session. I think you've all made the point several times that any discussion needs a set of clear expectations, whether we use our learners to help us make that plan or whether we have a plan and we want to be sure that the organization is clear, that the expectations are known. That's an important first step in any discussion getting off in the direction of learning. I'm particularly struck during attending rounds how many of our learners think that they're really there only to do the work and forget that by having you present in that team, it's a wonderful opportunity to be learning. Explore what your learners already know and listen for these common biases. They're in our own work as well, so listening for them in ourselves, encouraging our learners to understand those biases in themselves as well as in the work that they will do. Use questions such as, Gordo says that I could say that instead of Dr. Onning. Use the kinds of questions that ask for thinking, for connections, or for explanations, for implications, not just simple answers. Use questions that are about our learners and about the decisions that we're helping them to make, about the next steps, about the next best. If you think about some of the polls that I gave you, the options were all okay. Some, for you, appeared better than others. It's those kinds of questions that open up the thinking and discussion process. And last of all, don't be afraid to take some time to promote personal awareness for reflection and self-assessments. How did today go for you, in fact, is the issue in a final poll, if you would. And before we go to that final poll, just to point out, there is a second reference here. The How Learning Works is a very easy read. It is available for purchase, in an ebook or a paper book. But this second book down here, Understanding Medical Education, Evidence Theory and Practice, has a nice chapter on discussion, and it is free as an ebook in the UCLA Library Catalog. So I myself had a little trouble finding it, but there is something called an ebook catalog when you're in the Biomed Library website, and you'll be able to download that and follow up a little bit more if you wish. So reflecting on today, the three big ideas, and how you might bring those to bear on discussions, whether you're leading a topical discussion in a lab or a classroom, a case discussion as with a morning report or a resident conference, problem-based learning, or attending rounds. I hope that you picked up a tip or two about how things work. So we really appreciate your taking some time to spend this hour with us. We'd love for it to be interactive via audio. We haven't quite figured that part out, but thank you for being willing to work through the questions and for sharing your wisdom with us.